Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Somatic Mutations Predict Poor Outcome in Myelodysplastic Syndrome Patients After Hematopoietic Stem Cell Transplantation by Raphael Bejar et al. My name is Eliu Esty, and I am a professor in the Division of Hematology at the University of Washington Medical Center and a member of the Fred Hutchinson Cancer Research Center, both in Seattle, Washington, USA. My oncologic specialty is management of acute myeloid leukemia and high-risk myelodysplastic syndromes. In general, allogeneic hematopoietic cell transplant should be considered for patients with myelodysplastic syndromes when the perceived ratio of benefit, that is disease control, to risk, primarily transplant-related mortality, is higher than the comparable ratio with other options. As noted in the study by Bejar and colleagues that accompanies this podcast, death in most MDS patients after hematopoietic cell transplantation occurs in the presence of disease rather than solely as a consequence of transplant-related complications, whose incidence has declined in both older and younger patients over the past 20 years. Hence, while assessing the risk of death and morbidity after allogeneic hematopoietic cell transplantation, for example by incorporating comorbidity indices, remains important, the decision to recommend allogeneic hematopoietic cell transplantation for MDS principally rests on our ability to predict the probability of disease control after the procedure. Here, we might distinguish prediction, as quantified, for example, by areas under receiver operating characteristic curves, alternatively known as the C-statistic, and association, typically quantified by p-values. For example, using various criteria for resistance to AML therapy in 4,550 patients treated on SWOG, Medical Research Council, Hovon-Sack, and MD Anderson protocols, Walter et al. Found that while clinical factors, cytogenetics, and aberrations in MPM1 and FLT3 genes were strongly associated with resistance, p less than 0.001, inclusion of all these resulted in areas under receiver operating characteristic curves of only 0.71 to 0.77, indicating predictive power in between certainty, area under the receiver operating characteristic curve of 1, and the coin flip, area under receiver operating characteristic curve of 0.5. Since our capabilities to predict disease control after hematopoietic cell transplantation for MDS may be similarly circumscribed, Bejar's results et al. Are of great interest. Using massive parallel sequencing, the office screened for coding mutations in 40 recurrently mutated MDS genes in 87 MDS patients, median age 58, receiving a first hematopoietic cell transplant, 71% following reduced intensity conditioning, and 92% using donors' peripheral blood. Samples from another 4 patients failed the screening assay. Thus, 96% of patients were successfully screened, and outcome after transplantation was similar in patients in whom screening was unsuccessful or could not be attempted, as in the 87 successfully screened patients. 92% of the latter had at least one somatic mutation, most frequently in the ASXL1 gene. 29% of these patients had this ASXL1 mutation. Examining the effect on survival of mutations in each of the 17 genes mutated in at least 5% of patients, and after accounting via multivariate analyses for other covariates associated with worse survival, these were at least 5% marrowblasts, reduced intensity conditioning, complex karyotype, and unrelated donor. TP53 mutations, present in 21% of patients, increase the risk of death by 2.3-fold. DNMPT3A mutations, present in 18% of patients, increase this risk by 2.4-fold, and TET2 mutations, present in 13% of patients, increase this risk by 2.1-fold, with p-values 0.03, 0.05, and 0.03 respectively. To dissect the relative effect of mutations on disease control and transplant-related death, the authors excluded patients who died within 100 days of hematopoietic cell transplantation and found that mutations in TP53 and TET2 remained independent predictors of poorer survival. Interestingly, TP53 mutations were also associated with deaths within 100 days of transplantation. TP53 mutations typically occurred without other mutations, and although 57% of patients with complex cytogenetics had TP53 mutations, the effect on survival of the former largely resulted from its association with the latter. In contrast, TET2 and DNMPT3A mutations were not associated with the covariates noted above that conveyed shorter post-transplantation survival. Because TP53, TET2, and DNMPT3A mutations were largely mutually exclusive, 47% of patients had a mutation in TP53, TET2, or DNMPT3A. These patients had a median survival of 7.4 months, 4.6 months for patients with TP53 mutations, and a median progression-free survival of 4.6 months. In contrast, 60% of the 53% of patients without mutations in these three genes were alive without disease 3 years after transplantation. As in every paper, criticisms can be raised. Because the presence of minimal residual disease assessed by multiparameter flow cytometry pre-transplantation predicts relapse after transplantation in AML, patients in CR by morphologic criteria, that is less than 5% blasts, it would be useful to know the interplay between mutation status and measurement of minimal residual disease by multiparameter flow cytometry in the 48% of the author's patients who had less than 5% blast by morphology pre-transplantation, particularly since multiparameter flow cytometry is presumably simpler to perform than mutational analyses. Because 16 of the 18 patients with TP53 mutations received reduced intensity conditioning, here associated with shorter survival, it is somewhat difficult to distinguish the effects of TP53 mutations and reduced intensity conditioning. Nonetheless, as the authors note, most patients with MDS are not candidates for ablative conditioning. Mutations in TP53 and DNMPT3A were noted to be more frequent, and those in TET2 less frequent than in other cohorts, raising a question whether the effect of TP53, TET2, and DNMPT3A mutations in the author's relatively small cohort would be similar in other cohorts. The predictive ability of the author's models is quantified, for example, by area under the curve analyses, with and without information about TP53, TET2, and DNMPT3A might be informative. Nonetheless, assuming Bejar et al.'s data can be validated, I believe mutational analysis of TET2 and DNMPT3A, and particularly TP53, will eventually be done routinely in MDS patients who are being considered for allogeneic hematopoietic cell transplantation. This is analogous to current recommendations to test for aberrations in MPM1, FLT3, and CEBPA in patients with AML, at least those with normal karyotype. With AML, an objective is to spare patients with an NPM1 mutation without a FLT3 internal tandem duplication the risk of transplantation, since these patients likely will have long remissions or even cures with chemotherapy alone. With MDS, the goal would be to avoid standard hematopoietic cell transplantation in the approximately 50% of MDS patients unlikely to benefit. Of course, these patients might still be candidates for investigational approaches to transplantation. For example, those attempting to augment the graft versus tumor effect. While the current financial costs of screening are appreciable, these might pale relative to the costs associated with unsuccessful transplantation. This paper also raises several questions. Will mutations in TP53, TET2, or DNMPT3A persist at relapse post-transplantation, allowing them to be used as potential markers of minimal residual disease and thus potential signals for early intervention post-transplant? TP53, DNMPT3A, and in some cases TET2 are known to predict poor disease control in AML not treated with allogeneic hematopoietic cell transplantation. This similarity with transplantation suggests that both allogeneic hematopoietic cell transplantation and chemotherapy fail to target a final common pathway associated with poor outcome. And finally, will the somewhat arbitrary distinction between AML and MDS, now based almost exclusively on blast percent, be replaced by a system basing classification on mutational status plus or minus blast count? This concludes this JCO podcast. Thanks for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.